Hello and welcome to Insight Ophthalmology. I am Dr. Amrit and I welcome you to another lecture. Today we are going to study the trochlear nerve, that is the cranial nerve 4, along with its clinical correlates. So in this video we'll be talking about the clinical anatomy of the trochlear nerve, understand the unique features and the course of trochlear nerve, learn how to localize fourth nerve lesions at different anatomical levels. We'll also discuss the clinical features of the fourth nerve palsy in detail, clearly understand the compensatory head posture and its mechanism. We'll also cover the causes of fourth nerve palsy, and also most importantly we'll differentiate fourth nerve palsy from skew deviation, which is a very important differential and mimicker. The trochlear nerve is the fourth cranial nerve and it is a purely motor nerve supplying a single muscle, that is the superior oblique muscle. It has no sensory component. The fourth nerve is unique for several reasons. It is the only cranial nerve to emerge from the dorsal surface of the midbrain and it arises from the midbrain. It completely decussates, meaning the nucleus of one side supplies the contralateral superior oblique. It has the longest intracranial course of all the cranial nerves and it has the smallest number of axons, making it the thinnest cranial nerve as well. Because it is long and thin, the trochlear nerve is particularly susceptible to injury following trauma. Let's discuss the functional component of the trochlear nerve. The trochlear nerve carries general somatic efferent fibers and these fibers will innervate the superior oblique muscle. The superior oblique muscle has three main actions. Its primary action being intorsion, secondary action is depression in adduction, and tertiary action is mild abduction. These actions have already been discussed in detail in our video on eye movements. The trochlear nerve nucleus is situated in the midbrain at the level of the inferior colliculus within the periaqueductal grey matter. It lies in close association with several important structures. The medial longitudinal fasciculus, which interconnects the third, fourth and sixth cranial nerve nuclei and is essential for the coordinated eye movements and vertical gaze, is present in close association to the fourth nerve nuclei. Lesions here may cause internuclear ophthalmoplegia along with the fourth cranial nerve palsy. The mesencephalic nucleus of the trigeminal nerve, which carries proprioceptive afferents from the extraocular muscles including the superior oblique, also lies close to the fourth nerve nucleus. The inferior colliculus, which is an important relay center for the auditory pathway, explains why large dorsal midbrain lesions may also have an auditory association. Apart from that, the superior cerebellar peduncle and its decussating fibers can be seen here. These carry efferent cerebellar fibers to the red nucleus and the thalamus, which was discussed in our previous video on oculomotor nerve anatomy. Involvement of these fibers can lead to ataxia and coordination defects. Let's discuss the course of the trochlear nerve. The trochlear nerve has four main parts: the fascicular part, the precavernous or cisternal course, the intracavernous part and the intraorbital part. Let's discuss the fascicular course. Fibers arising from the trochlear nucleus, which is situated in the periaqueductal grey matter, they form fascicles and they pass in between the inferior colliculus and the periaqueductal grey matter and completely decussate in the anterior medullary velum that is present as the roof of the fourth ventricle. This decussation occurs at the dorsal part of the midbrain. This explains why nuclear lesions can cause contralateral superior oblique palsy and why bilateral palsy can occur in this region. Before we go further, let us briefly understand the tentorium cerebelli, because this structure is extremely important for appreciating the course and vulnerability of the trochlear nerve. The tentorium cerebelli is a fold of dura mater that forms a tent-like roof over the cerebellum and it separates the cerebellum below from the occipital lobes of the cerebrum above. It has two margins, an attached margin and a free margin, and both are anatomically and clinically important. The attached margin is the peripheral fixed margin and it is attached to the petrous part of temporal bone, the posterior clinoid processes and the occipital bone. Because it is firmly anchored to the bone, it forms a rigid boundary and does not move. The free margin, on the other hand, is the medial sharp crescent-shaped edge of the tentorium that you can see in the diagram. And this free margin forms the tentorial notch through which the midbrain passes to connect the cerebrum with the brainstem. Now, this relationship is very important. The trochlear nerve, after emerging dorsally and wrapping around the midbrain, it runs just beneath the free margin of the tentorium cerebelli before piercing the dura. Because the free margin has this sharp dural edge, the trochlear nerve is particularly vulnerable to stretching and compression at this point, especially in trauma or raised intracranial pressure. So, in the cistern, the trochlear nerve passes between the posterior cerebral artery and the superior cerebellar artery and runs parallel to the posterior communicating artery. Next, let's discuss the intracavernous course. The trochlear nerve enters the roof of the cavernous sinus and then runs in its lateral wall. It lies just below the oculomotor nerve and just above the ophthalmic division of the trigeminal nerve, that is V1. This explains why the cavernous sinus lesions rarely produce isolated fourth nerve palsy, because the fourth nerve is in close association with the third nerve, V1, V2, which are the divisions of the trigeminal nerve, and also to some extent it is in close relationship with the internal carotid artery and its sympathetic plexus, and also the abducens nerve, which is in the floor of the cavernous sinus. Next is the intraorbital course. The nerve enters the orbit via the superior orbital fissure outside the annulus of Zinn through the lateral compartment along with the lacrimal and frontal nerves and the superior ophthalmic vein. So you can see the same thing being represented in this diagram. The trochlear nerve, after emerging from the superior orbital fissure, passes medially above the levator palpebrae superioris muscle and supplies the superior oblique from its orbital surface. So that's important. Every muscle has an ocular surface and the orbital surface, which is facing towards the orbit. So it's through the orbital surface that the trochlear nerve is going to enter and supply the muscle. So that's important surgical anatomy for you. Now that we understand the anatomy in detail, let us move on to the lesion localization. Midbrain lesions. Lesions involving the trochlear nucleus or fascicles can produce bilateral fourth nerve palsy because decussation occurs at this level of the midbrain. These patients may present with bilateral fourth nerve palsy, may present with a V pattern strabismus, especially in down gaze. Also, they can have ataxia due to involvement of the superior cerebellar peduncle. Moreover, since the medial longitudinal fasciculus also lies close by, they can develop internuclear ophthalmoplegia as well. Sometimes there might be involvement of the crus cerebri leading to hemiparesis, and rarely there might also be a possible involvement of the cranial nerve 3 if the lesion extends superiorly also up to the level of the superior colliculus. Such findings point towards a central or a nuclear trochlear nerve palsy, commonly due to a large infarction or hemorrhage at the level of the midbrain. Next is the subarachnoid lesions. Because the trochlear nerve is long and thin, it's particularly vulnerable in the subarachnoid space along the sharp border of the tentorium cerebelli. Common causes over here include trauma, meningitis, subarachnoid hemorrhage, and even an aneurysm might come and press over the fourth nerve. Most traumatic fourth nerve palsies occur at this level and may be bilateral and also asymmetric. So remember that. Next, we have the cavernous sinus lesions. When the trochlear nerve is involved within the cavernous sinus, it is important to remember that this is a very compact anatomical space containing multiple neurovascular structures. Because of this, isolated fourth nerve palsy is uncommon at this level. Within the cavernous sinus, the trochlear nerve runs in the lateral wall along with the oculomotor nerve, V1 and V2 divisions of the trigeminal. And medial to these structures lie the internal carotid artery, which is surrounded by the sympathetic fibers, and therefore lesions in the cavernous sinus typically produce a constellation of findings rather than a single nerve palsy. Common causes here include cavernous sinus thrombosis, carotid cavernous fistula, tumors such as meningiomas, or even a pituitary adenoma with a lateral extension into the cavernous sinus, inflammatory conditions like Tolosa-Hunt syndrome, and also aneurysm of the cavernous portion of internal carotid artery. And therefore, these patients are going to present with combined cranial nerve involvement of cranial nerve 3, 4, V1, V2, 6th involvement. Pain also is an important feature here, often severe and retroorbital pain. And sensory loss occurs over the area of forehead, cornea, cheek. Why? Because of the trigeminal involvement. Ophthalmoplegia because of multiple extraocular muscle palsy. That means not just the superior oblique but also other muscles supplied by the third cranial nerve will get affected. And if the sixth cranial nerve get affected, even the lateral rectus will get palsied. Horner syndrome due to disruption of the sympathetic fibers, resulting in ptosis and meiosis. Now let's move further anteriorly into the orbit. So when the trochlear nerve is affected within the orbit, it is again uncommon for it to be involved in isolation because the crowded nature of the orbital apex and the superior orbital fissure. The orbital involvement may occur because of orbital trauma, including a blowout fracture, orbital inflammation such as an idiopathic orbital inflammatory disease, orbital tumors, orbital cellulitis, or hemorrhage within the orbit. So at this level, the trochlear nerve lies in close proximity to the similar nerves like oculomotor nerve, ophthalmic division of the trigeminal nerve, orbital vessels, extraocular muscles, and also don't forget the optic nerve. And therefore, patients with orbital fourth nerve palsy or lesions at the orbital apex will present with additional orbital signs, including proptosis. This is why, because of the mass effect, is something behind the globe which is pushing the globe forward, leading to proptosis, chemosis because of venous congestion, periorbital or orbital edema, pain, especially with eye movements, visual impairments because optic nerve is getting compressed, restriction of eye movements in multiple directions. So in orbital trauma, hemorrhage or edema can selectively affect the trochlear nerve because it is thin and superficially placed, particularly as it enters the superior oblique muscle. Okay, thus the presence of a local orbital sign along with multiple cranial nerve involvement strongly points towards an orbital cause rather than a central or a cisternal lesion. Now let's discuss a very important clinical pearl, that is the concept of ipsilateral versus contralateral fourth nerve palsy. This is a very important concept. Now all the lesions which are occurring before decussation of the fourth nerve, which occurs at the anterior medullary velum or at the dorsal part of the midbrain, will result in a contralateral superior oblique palsy. Whereas lesions after decussation, that is from the subarachnoid course and beyond, will cause ipsilateral superior oblique palsy.